let's start with you, Bill. Can you give us an example of a program that you all are working on or have already implemented that's really been a success as far as the implementation of healthcare across the community?
Well, I'd rather talk about what we're doing in the sense of a portfolio instead of a program. I sometimes think that we draw arbitrary boundaries around our programs. And so what we're managing at DHMS, and frankly, as we move forward in conjunction with the Coast Guard and the VA, part of the Federal Electronic Health Record Modernization Office, is the delivery of capabilities, IT capabilities to support VA, DoD, and Coast Guard, and potentially other federal healthcare providers across a full spectrum, right? So we put a lot of focus on up front on getting the electronic health record, MHS Genesis, and the shared implementation with VA and Coast Guard deployed. So DoD has, we started a few years ago. I think we really started back in 15. We did some initial sites. You may recall there were some observations that it was not perfect at our initial sites. We learned a lot from that. Sure. This past September, we went to 4 sites in what we called Wave Travis, which was tremendously successful. So we have 8 sites running. When COVID happened and we all had to look at things differently, what we found, what we observed was, and I talked a little bit about this earlier, is that where we had deployed the modern EHR, that we enabled the healthcare providers to be more adaptable, more resilient, and more responsive to the changing, unknown future needs and changing needs of responding to COVID, new COVID tests, how to order them, things like that. Where we had the new system in place, the new capabilities in place, we were able to make those changes inside a day, actually in less than a half a day, get the updates to training out there, and clinically have people prepared to use them, providers prepared to use them. Where we were dealing with the legacy environments, it took months to get the same thing accomplished. So very exciting. And I talked earlier about how we were able to pull back the operational, pullback's maybe a poor choice, but use the operational medicine technologies that we generally used with deployed forces, right? Think, Afghanistan, people might be using it there. Low bandwidth, and so the 5G and the Verizon talk was very relevant there because we're shifting to all network delivered capabilities and data. But pull those capabilities back. Provide our operational medical situational awareness capabilities to CONUS so that we can get insight into where beds are available, where PPE is, and what the situation is in the military health system, and how it all ties together and ties back to the record. And then also take that same set of technology, the operational medicine technologies, and apply it to delivering care in non-traditional environments, right? Going back to the data conversation. We're collecting this data. We have a very rich and very broad collection of data about people, about patients. How do we get that to where the care needs to be delivered? And where care needs to be delivered has shifted. Our whole understanding of that has shifted away from the traditional fixed medical center that people are accustomed to, and we talked about that a little up front, and we need to be more flexible. Because of COVID, and as we go through the COVID, we realize there are other advantages to it, and we're open to creating the capability to do that more broadly.
You got to